vaporizers Osce. Risha, have you had a chance to learn about vaporizers?
Yes,
Have you
sir.
attended any class?
Yes, sir.
Okay. And so first we start with the leftover equipments and circuits, and then we will come to the vaporizers and complete the class. Okay.
Yes, sir.
So I will share my screen with you now. Is it visible?
Yes, sir. Visible,
Sir.
sir.
Okay, right. So, so you are seeing some pictures here. Can you identify what is being shown here? What is shown here and why knowledge of the various systems is important for the anesthesiologist?
Pictures shown are Meggle's breathing circuits, sir.
Only Megil circuit?
Mm-hmm.
You find a common name in all the 6 pictures.
Circuits, sir.
Wilson's circuits.
No, Mapleton circuits. Sir.
It is a Mapleson's classification of which type of breathing system. Is it closed or semi-closed or open or semi-open?
Semi-closed, sir.
It's semi-closed. Very good. Professor Mapleson classified the semi-closed breathing systems into what are all the categories he divided. Did he very first time did he describe all the 6 A, B, C, D, E, F, or did he stop with something and then later on something were added?
Sir, F was added later on.
Yes, very good. F was added later on. So only the 5 classification, Mapleson A, B, C, D were and E also were prescribed or described by Mapleson. And then when Jackson Ree made a modification of the IRTPs, it was called Mapleson F or Jackson Ree circuit. Okay. So this is the common circuit which you are all aware of, McGill circuit. What is the importance of this classification? Why did he classify this into these categories? Why Mapleson had to classify the semi-closed breathing systems into these categories? What are the advantages or disadvantages? Why, as an anesthesiologist, you should know the functioning characters or principles of these circuits.
One is the position of fresh gas flow on the APL valve. Based on this,
Very good.
we can use this for
So
patients.
only
with
two important factors. One is fresh gas flow and APL valve, or something else also is important.
rebreathing.
The reservoir bag or the rebreathing bag. So all the 3 components: fresh gas flow inlet, the APL valve, the reservoir bag position. All these 3 decide. What do they decide? Keeping them in one position. If you observe this picture, Mapleson A is having the fresh gas flow from this point, whereas in Mapleson B the fresh gas flow is very close to the APL valve. And if you see Mapleson C also, fresh gas flow and the APL valve are close together, but the corrugated tubing is absent. And in Mapleson D, if you find fresh gas flow is in the front, APL valve has gone behind, and reservoir is the largest at the farthest place. So like that, the position keeps changing in each circuit. So what is the importance of this relative positions of these 3 components: fresh gas flow inlet, the APL valve, and the reservoir bag? In what way it is important?
So one thing
What?
can be used for control
fresh gas
ventilation.
flow needed
Very
in
good.
The other is suitable for spontaneous ventilation.
Spontaneous ventilation. Very good. So by you interchanging or wrongly using a circuit, what will happen? You say some circuit is best suited for spontaneous, some circuit is best suited for controlled ventilation. So by mistake, if somebody does not know which circuit to use, supposing I use this McGill circuit for controlled ventilation, what will happen? McGill circuit, all of you know, you will have carbon dioxide accumulation. CO2 will be going on slowly accumulating, and patient will land up with hypercarbia at the end of the anesthesia. If you give anesthesia for 1 to 1.5 hours using McGill circuit by closing all the valves and then using a fresh gas flow and paralyze the patient and manage the ventilation by squeezing the reservoir back, then at the end of anesthesia, if you take an ABG, you will find the carbon dioxide level would have shot up to somewhere around 60, 70, and patient will be in deep coma, not responding because of hypercarbia. Okay. On the contrary, if you use brain circuit, can you use this Mapleson B for controlled as well as spontaneous ventilation? Yes or no?
Yes, sir.
Yes, it can be used for both. So Bain circuit can be used both for controlled ventilation as well as spontaneous ventilation. How is it possible? When you say that you can use McGill circuit mostly for spontaneous respiration and not controlled ventilation, how is it possible to use Mapleson D or the Bain circuit both for a spontaneously breathing patient as well as when you want to control the ventilation? How is it possible? What is the principle under this?
We have to change the flow, fresh gas flow according to the.
Okay, that is one of the criteria. But what helps the Bain circuit to be suitable for both spontaneous as well as controlled ventilation?
The position of APL valve is easy.
Position of APL valve is farther away here.
Yes.
The rear end of the circuit. Fresh gas flows here. Okay. So the dead space, the apparatus dead space is very minimal in Bain circuit. Okay. So any circuit or any breathing system, when you use, you must choose the system which has the least apparatus dead space. As all of you know that you all listened to the respiratory mechanics 2 days ago in the class. Dead space ventilation is the ventilation which is not taking part in gaseous exchange. So it is not able to give the oxygen to the body and remove the wet carbon dioxide from the body. So if you add more and more dead space, it will be a wasted ventilation. It will not be able to take part in the gaseous exchange. So any circuit when you choose, you should make sure that it has got the least amount of apparatus dead space. And this apparatus dead space is decided either by the point of entry of fresh gas flow or the location of the APL valve. So if you see the McGill circuit, the APL valve is here, whereas fresh gas flow is coming from the rear end of the circuit or the system. So if you keep this valve open, the dead space will get which will end here. The apparatus dead space will end here because all the gases can leak out through this APL valve. Similarly, if you use the Bain circuit, the apparatus dead space will again end here because the fresh gas flow entry is here. Okay. So because of the position of these two things, APL valve in McGill circuit or Mapleson A and fresh gas flow inlet in Bain circuit, they decide the apparatus dead space. So here you have to keep the valve partially open, then it cannot become a closed circuit for controlled ventilation. That is why it is best suited for spontaneous respiration. Whereas here, the fresh gas flow entry is here, so apparatus dead space will end in this position. So it can be used both for spontaneous respiration as well as controlled respiration. So by closing the APL valve, if you paralyze, then you start squeezing the bag and produce a controlled ventilation. On the contrary, when you want to regain spontaneous respiration, you partially open this APL valve, allow the spontaneous effort to resume, and you can use the same circuit for spontaneously breathing patient also. Okay. So what are the examples of other circuits which are used? Where are they used? Is other knowledge that you have to use. And of course, Jackson tree is mainly for which type of patients?
Pediatric patients.
Pediatric age group.
Pediatric patients
Weighing
weighing
less than 25
20 kilos. Very good. So that is a very important caveat that you cannot use it for a 10-year-old pediatric patient who weighs 50 kgs. Okay, so less than 20 kg children, babies, you can use it. And the original construction was, why it is called IRTPs or IR circuit? Because it was designed by one Dr. Iyer, okay, British anesthetist, who called it like a TPs because it has got this fresh gas flow inlet. This is the expiratory limb. This is the inspiratory limb. So if you see the shape of this, supposing you imagine this is being extended a little bit, it looks like the alphabet T. Okay. So the components, examiners, they may ask you, sorry, what are the components of IRTPs? The three limbs. One limb is for fresh gas flow entry. The other limb is for expiration. The third limb is for inspiration going to the patient. It may be attached to the face mask or an endotracheal tube. So inspiratory limb continuing as an expiratory limb intercepted by a fresh gas flow inlet. So these are the three components of the IS TPs. The T is a alphabet T, English alphabet T. And some people call it as Bain 2 also. And the modification done for Jackson trees is, what do you find here?
Reservoir bag is there.
Any other adjective to be added to the reservoir bag?
APL
Instead
valve.
of APL valve, there is a opening in the end of.
That is called open tail reservoir bag. This is called the open tail. That is the original description by Jackson Tree, because if you find this, if you look at this IRTPs, there are no valves like this. What you find here in the other four circuits, there is no valve at all in the IRTPs. So he made it mainly for very small babies for spontaneous respiration before the era of muscle relaxation and controlled ventilation being done in pediatric patients. They were doing all surgeries by the babies breathing spontaneously. So for that, Iyer wanted to construct a circuit or a system without any spring-loaded valves, so that children can easily breathe without any resistance. So when Jackson Tree, who was assistant to Dr. Iyer, when he wanted to modify this by adding the bag, he didn't want to incorporate any valves, which will defeat the purpose for which Iyer constructed this for babies. So the original description is a open tail half-liter reservoir bag attached to the expiratory limb. What made Jackson Tree think of adding this bag to the expiratory limb? Why did he think of adding this reservoir bag? If you use IRTPs, can you monitor the breathing of the baby when
No,
you are
sir.
using that? So you don't know,
Volume and
especially if the baby's face and the upper part of the body is covered during draping of the surgery, you won't know whether the child is breathing or not unless you look at the operative field and look at the movement of the abdomen. So to monitor the respiration, Jackson Tree first of all wanted to add this bag so that you can see the movement of the bag, whether the child is nicely breathing or not. And second thing, whenever you want to assist the respiration, supposing the baby is hypoventilating, then you can pinch and close this bag and then squeeze the bag so that you can assist the ventilation also. So the two reasons why Jackson Tree added this open-tailed reservoir bag, one is to monitor the respiratory attempts of the patient. Second is to assist the respiration whenever needed by pinching and closing this tail so that you can squeeze the bag and then improve the tidal volume in the patient. Okay, so you can even do controlled ventilation by paralyzing by squeezing this. Later on, our people who manufacture this system or circuit, they have added the valve like this in the end or in the middle. That is not at all the original description by Jackson Ree. So this has been made for our own convenience because we are not comfortable doing the pinching and squeezing and releasing technique. So we have added the one spring loaded valve there. Of course, that is not the original description that you want to know. So if you see the description here, you have the 6 classes A, B, C, D, E made by up to E was the original description by Mapleson as I see. And if you see the location of fresh gas flow, in A it is very close to the reservoir bag. You can see here the fresh gas flow and reservoir bag are close to that, whereas the APL valve is near the patient end. And there is a reservoir bag present, there is a corrugated tubing present, and the examples are MAC and LAC circuit. What is this LAC circuit? What is the construction of LAC circuit? And what is the comparison between Bain circuit and LAC circuit? This is another common question examiners may ask you.
It's a coaxial
Bain circuit is a
circuit.
Very
It is
good. First
modified.
answer, you must say it's a coaxial circuit. In what way it is different? Bain also is a coaxial circuit because there is an inner tube and an outer tube. The difference is in Bain circuit, the inner tube is the delivering the fresh gas flow, and the outer tube is the expiratory limb. The opposite is there in LAC circuit. Okay, the outer limb is the fresh gas delivery tube, and the inner limb will be the expiratory flow tube. Okay, so that is the major difference between the two. So when the inner tube is there as a delivery tube, that is why you get the fresh gas flow entry very close to the patient, and apparent dead space is very much low. Whereas in LAC circuit, it is mainly again for spontaneous ventilation. You cannot use it for controlled ventilation because the inner tube is the expiratory limb and outer tube is the inspiratory limb for this patient. Similarly, if you see the B classification, what he made has got a little bit of change here, that the fresh gas flow and APL valve both are very close to the patient, and there is a reservoir bag corrugated tube, but this is not commonly used anymore. And C also, he changed the position. The only difference is there is no corrugated tube here, the length of the tube. So it was mostly, examiners may ask you, it mimics the ambu bag because there is no corrugated rubber tube. The equivalent of Mapleson C is the modern ambu bag which we are using because there is no corrugated rubber tube here. And Mapleson D is the Bain's tube, Bain circuit, and E of course is ISTPs, and EF is Jackson Ree's modification which we discussed. Okay, so this is the, these are all the points that you have to know with regard to this. Now something is displayed here. Can you identify what is this?
It's Bain circuit.
Bain circuit.
Bain circuit used for adult or children?
Adults.
It's an adult Bain circuit, correct. So you can see the length and other. So this adult Bain circuit. What about this?
Pediatric Bains.
This is a pediatric Bain circuit. You can see the length is quite smaller, the larger tube, and for to identify that, sometimes they may give you a small face mask here. Transparent pediatric face mask is given. So this is the pediatric Bain circuit with a mask. Okay. So what are the dimensions of Bain circuit which are used in the normal anesthesia and the one used in MRI room? Bain circuit is the most preferred circuit for patients who are anesthetized and the MRI investigation is being done. So you have to keep your machine, everything well away from the MRI console. So what should be the length of the vein circuit in the normal circuit used for anesthesia in the operating room? And what is the length of the vein circuit used in MRI?
Normal one is 80 centimeter.
80 centimeters.
80
That
meters.
is it 0.8 meters?
0.8.
0.8, only 0.8? It's much more bigger than that. Does it look like 0.8?
180
meters.
centimeters, sir.
Normal is 1.6 double. Okay, only 1 meter 60 centimeters or 1.6 meter is the normal length used in anesthesia. It's quite a long thing. Okay, more than a meter, and it is almost 3 times that, more than 3 times, 5.4 meters for MRI. And both have a 22 mm outer corrugated tube and a 6 mm inner green PVC tube. So you can see this inner PVC tube, green color, going up to the patient end. So that is why the fresh gas flow goes up to this. So the apparatus gets space only beyond this. Okay, that is the reason why it is a very, very advantageous circuit. So it comes from here, goes like this. So the inner tube is a 6 mm diameter tube, green PVC tube, and these are 22 mm connections. And the normal length for anesthesia used in OT is 1.6 millimeters, whereas the MRI suit vein circuit will be 5.4 meters, so that it can be well away from the MRI 50 gauge line, the so-called 50 gauge line. What are the indications for uses of pediatric vein circuit? When will you use the pediatric vein circuit? Used mainly during endoscopic procedures in children as well as in MRI suit. Okay, so these are the two indications for vein circuit in pediatric patients. Now identify the circuit shown here. What are its advantages and hazards? What is this circuit?
Maples and F
C-type,
circuits, sir.
Maples and F for Jackson trees. Very good. Okay.
Jackson
So even
trees.
though it looks like vein circuit, there is no inner tube here. Okay, it's only a simple corrugated tube. This is the fresh gas flow entry tube with a carrying tube to attach to the machine. This is the open tail reservoir bag. You can see this is the original bag where there are no valves attached. This is the open tail half-liter bag attached to the Jackson tree circuit. So also known as Mapleson F. What are the advantages? One is lightweight and portable. Any other advantage you can mention about this?
Dead space is
Apparatus
minimum when
dead
compared
space
to
is
the
less.
usual veins.
Fantastic, very good. Normal, no valves, so nil resistance, ideal for spontaneous breathing in children, which I told you earlier. Can be used for both spontaneous and controlled ventilation because of the minimal dead space. So minimal apparatus dead space is also there. These are all the advantages of this Jackson tree. Lightweight and portable, no valves, and nil resistance, zero resistance actually, and can be used for both spontaneous ventilation as well as controlled ventilation. As I told you, by closing this tail, you can squeeze the bag and give positive pressure ventilation, release the tail, and the exhalation will occur through that. And it's a minimal apparatus dead space. These are all the advantages of this circuit. What are the hazards of using this circuit?
So the occluding and opening should be sequential. Otherwise, the rebreathing and hypercapnia will be.
Rebreathing and hypercapnia is not a possibility. Rebreathing depends on the expiratory limb, not on the technique that we use. Okay.
Okay, sir.
If you have a too large expiratory limb, then patient will rebreathe the exhaled gases and develop hypercarbia. If you have a very short expiratory limb, then air dilution will occur because it will suck the atmospheric air. That is one of the disadvantages of the expiratory limb. But in a spontaneously breathing circuit with an adequate volume of expiratory limb, the rebreathing of carbon dioxide is very, very minimal. What is the flow rate you require whenever you use Jackson trees or Mapleson F for a pediatric patient? And you use just the minute ventilation equal fresh gas flow?
2 times the minute ventilation.
It has to be 1.5 to 2 times the minute ventilation. Requires a very high flow rate to prevent rebreathing and air dilution. And because of this, what are all the complications that can be produced? When you have to use a very high fresh gas flow, what are the disadvantages because of that? Is it economical to use a very high fresh gas flow?
No, sir, more amount of vaporizer will be needed.
More
Will be
amount
used
of?
up. Vapor, if we are using any volatile agents, more amount will be used up if we are giving
No,
fresh
don't
gas
mix
flow.
up with volatile agent. When you have to use a fresh gas flow, very high flow for say 2 hours surgery, you may are doing a major laparotomy in a 6 months old baby weighing only about 5.5 kg, and you use twice the minute ventilation for 2 hours. Is it going to be economical, cheap, or more expensive? A high flow will be always expensive, isn't it? Especially if you are going to use nitrous oxide and oxygen, you will have to use more flow. You will be spending more, number one. Where will all the gases go in this circuit? When you release the...
It will be
There
inside
is no
the
scavenging.
if you don't use scavenging properly, you will be polluting the theater. Okay. And the gases that you are supplying to the patient, are they humidified? Is there any chance for humidifying the fresh gas flow that you are giving?
No, sir, unless we put a filter separately.
So it is mostly dry gases which you will supply. Okay, so all the problems of this are hazards of this circuit are based on because of the high flow. What happened? Wastage of anesthetic gases, OT pollution will happen, is uneconomical, and if you use this circuit with the dry gases for a long time, the drying of the respiratory tract will happen because there is no humidification, and post-operative respiratory complications are more. This. So for short term, it is good. That is why nowadays we have pediatric closed circuit with carbon dioxide absorption. Small canisters are there which are used, which will have all the benefits of humidification, heating the gases, and with no wastage of gases and pollution can be done. So the usage of this circuit for major surgeries lasting more than 1 hour is now not recommended, and we can straight away go for pediatric circle systems which will provide all the benefits or avoid all these hazards. Okay, so that is the answer for that. Now, can you identify this?
TPs, sir.
This is a which type of TPs?
Maples and E.
ISTPs.
This is a TPs, but this can you see the material out of this is made up of this
Corrugated metal tubes.
it's a original metal, heavy thing. Okay, all these things are stainless steel. So the earlier version of the ISTPs or Mapleson E system were very quite heavy. So they used to drag on the endotracheal tube. Supposing you use this, you have to have an adapter here for the endotracheal tube, and this end will be open, and you cannot monitor this also, as I told you earlier. So this is a fresh gas flow, this is the patient end, and this is the reservoir. R is standing for reservoir. So this is the corrugated tube provides the reservoir for the next inspiration, and expiratory tube also goes out through this. So this is the metal ISTPs. What is this bag? Is it a reservoir bag? Does it look like a reservoir bag? Similar to this? The shape looking, yes or no? At least say yes or
Yes,
no.
sir. Yes, sir.
It looks like a reservoir bag, but the opening is here. Okay. So somebody wanted to modify this bag, as somebody said it is very difficult to pinch, close and squeeze and release. The synchrony is very difficult. So instead of that, if you just close this with your thumb and squeeze, you can deliver the gases. You take off your thumb, it can be easily do the expiratory exhalation of the gases. So somebody wanted to modify the gas and you are not incorporating any valve here. So any name for this bag? It was tried as a reservoir bag in Jackson 3 circuit instead of the open tail bag. This is called the Kun bag, Khunbag, Kun bag. Okay, so it was. This is used in some countries, especially in the Korean countries. They use this, and these are the various types of T pieces. Can you name all these things? There are 4 types of the same T piece. This was the original T piece. The inspiratory fresh gas flow, inspiratory limb, expiratory limb. Then this was modified to accommodate the corrugated tubing plastic version. Then the inlet tube was curved a little bit, and then this is the fresh gas flow, this is the patient inlet, this is the expiratory limb. So they are called, this is a classic model, this is a modified classic model or ISTPs. This is called the Washington modification of ISTPs, and this is called the Norman modification of ISTPs. Okay, so sometimes this can be given in the Osce, so you should know classic, modified classic, Washington, and Norman. These are the 4 types of modifications of TPs. Now name the parts of the laryngoscope which you are using commonly every day. There are markers here to show what are all the parts. You should be able to identify the parts of the laryngoscope.
Sir, handle.
Yeah, this is handle. Very good. Handle, what does it contain?
It has a battery, sir.
This has the power batteries inside. Okay, 2 batteries can be put inside. That is the handle with the battery enclosure. And what about this?
Hook and
What are
hinge.
these?
Hook and hinge.
Hook and hinge. Very good. What about this?
Flange.
Flange. Okay.
Tongue of the blade, sir.
Tongue of the blade. Very good.
Then
So
tip.
you have identified almost mostly. So this is the handle with a space for battery. This is called the hook on base. So you can just slide it in and fix it. Earlier it used to be a hole and a screw, earlier versions, but later on it was modified for easy fixation, what is called the hook on base. Then you have the vertical step, this is a flange. This is called the beak tip. You will always find there will be a small rounded beak tip so that you don't cause any injury. And this is the tongue blade or the spatula. Okay, so all these things are the parts which can be sometimes asked. What is shown here?
Macintosh blade and Miller's blades with
Miller
various
blade,
sizes.
curved. You must always say Macintosh curved blade and Miller straight blade. Okay, even though your answer is correct, always give a full description. Varieties of normal standard varieties of or sizes of Macintosh curved blade and standard sizes of Miller straight blade for pediatric to adult use. Why this straight blade? Original invention was by Macintosh to produce this curved blade, but later on the modification was to use the straight blade. Why? What are the advantages of straight blade over curved blade?
So since pediatric epiglottis, they are usually bigger and floppier, we can include the epiglottis with a straight blade.
Fantastic, right? That's a correct answer. So you must always be ready to tell this answer in the exam. So it was mainly meant for pediatric use, especially newborn babies. They could not identify the glottic opening using the curved blade. So they used the straight blade, which will include the epiglottis and lift it up so that you will have a clear vision of the vocal cords and you can So curved and slate blade laryngoscopes, Macintosh and Miller, various size blades. Okay. What is this instrument?
McCoy's.
McCoy's, very good. This is called the McCoy's. What is the advantage of McCoy?
The flange is, it can bend when we give a maneuver.
The tip, not the flange. This tip
Sorry,
portion,
it
you
can-
can see there is a connection here. And when you press this lever, this will be able to lift the epiglottis without anybody helping you. Okay. So that is the advantage of McCoy blade. Do you know the name of the Indian version of this McCoy blade? This is the original imported version, McCoy blade laryngoscope. One Indian company is making a similar model where the tip alone can be bent by pressing a lever, and they have given Indian name for that. That's called Tripti, satisfaction. In Tamil and Sanskrit, Tripti means you are satisfied. So they have given the name Tripti for the Indian version of McCoy blade. Okay, right. What is this? There's a clue here. Voice surgeon.
Foreign body removal.
Foreign body or any laryngoscopy, microlaryngeal surgery scope. So this is a scope used for microlaryngeal, and this is the forceps which is used. You can see there is a tip opening. So small polyps in the vocal cord or small growth in the vocal cord for biopsy, all that can be done. So this will be fixed. This is a rigid scope which can be fixed in position with the support here, and you can use this for removal of the growths in the vocal cord. What is this?
Rigid bronchoscope.
Rigid bronchoscope, rigid ventilating bronchoscope. You can see this is the connection for your ventilation, and this is the side port, this is the eyepiece, and this is the light source attachment. So this is a rigid ventilating bronchoscope which can be used for foreign body removal or inspection. And this is how the attachment for ventilation will be done. Here I am showing only the connector here. Here I have shown the entire circuit for ventilating the patient. What is this? It's an equipment used for foreign body removal, during foreign body removal.
Flexible bronchoscope.
This is it's a small needle here. Then there is something like a switch here. There's a tube. There is an adapter. So this is called the Sanders jet ventilator. Okay, so this will go to the gas source, and high pressure gas will be coming through this. And this is the control switch. By pressing this knob, you can open the gas or close the gas. And this needle will be attached to the side of this bronchoscope. Okay, so this will entrain the atmospheric air and it will ventilate the patient. So this is called the, what is the principle involved in jet ventilator? How does it? Venturi principle. Okay, most of you would have heard about the Venturi principle. So Venturi principle is used in Sanders jet ventilator, and this is a slight modification of what is originally designed. You are finding something extra here, some other mechanism here. What is this called? So you can read the pressure in the circuit so that you don't cause barotrauma, because you are going to use a high pressure which will be delivered at the tip, and that will entrain atmospheric air to increase the tidal volume or the inspiratory volume. And this is the control lever for that. Whereas here you find this is a pressing like switch. So this is called the manu jet. Manually you operate the jet, so it is called the manu jet. So this is Sanders jet ventilator, and this is manu jet. Both of them used during bronchoscopic ventilation. or for removal of foreign body or inspection. For all these purposes, you can paralyze the patient and continue to ventilate the patient using these equipments. Okay. So what are shown here?
Goodell's oropharyngeal airways with various sizes.
Color coded. Always,
Color-coded.
whenever the color is given, please mention that also in the Osce exam answer. It is a color coded oropharyngeal airway. Color coded oropharyngeal airways, originally designed by Goodell. Okay. What are these?
Nasopharyngeal airways.
Nasopharyngeal airways of different sizes.
Various sizes.
Okay, here it is only written the number ID number. It is not color coded. So this is a various sizes of nasopharyngeal airway. How to measure the size of the overall or nasopharyngeal airway? How will you choose the correct size?
From the angle
Stages
of
to
the
all of nasal.
So for oropharyngeal airway, you have to take it from the angle of the mandible to the corner of the mouth. Okay, angle of the mouth. So that is how you select the size of the oropharyngeal airway. For nasopharyngeal, from the ala nasi to the tragus. Okay, so that is how you measure the oropharyngeal and nasopharyngeal correct size, so that you don't traumatize or introduce it too long. Okay. I have given the name also for those who could not identify. Where is it used? This Ovasapien airway.
For fiber optic.
Very good. So this is used mainly for, it's called Berman airway for fiber optic intubation, and this is how these two airways are used. So you can introduce the fiber optic scope after putting this airway in the oropharynx. You can introduce the scope through that. Why do you have to use this?
While performing awake fiber optic to avoid
Yes.
patient biting the fiber
Biting the fibroscope. Excellent. That is the reason. Okay. Especially if you are doing it under topical anesthesia in an awake patient, to prevent the patient biting the fibroscope, okay, which will spoil the filaments inside this. So in order to avoid that damage to the fiber optic scope, you can use the oral pharyngeal airway. So fiber optic scope through the above airways. What are the things that are shown here? If you are seeing every day in your
Color-coded suction catheters.
color-coded suction catheters. Okay?
Suction catheters.
Suction catheters which are color-coded, various sizes. So these are all the sizes you must be able to identify. Commonly, which size we use? We use a 10 French. Okay, black will be using. For pediatric, you have to go for a smaller size. For adult, commonly we use a 10 French black color suction catheter is the ideal one for adult. So color coded for size. What is this? In this tube, if you attach it to the suction tip, metal tip or the plastic tip and use it, do you have a control over the suction?
No, sir.
No, it will be sucking continuously. Okay, whereas here you have a
Reploger tubes.
Intermittent suction.
it's a tube which you can suction catch with a control, pressure control. Okay, you can Reploger tube is used for the pouch in the tracheoesophageal fistula to empty the upper pouch. Okay, Reploger is something different. This is not Reploger. So this is a normal suction catheter with a thumb control, pressure control opening. Okay, by occluding this, no suction will happen. Once you take out your thumb, suction can happen. So while introducing, you can keep your thumb here and occlude and prevent any suction being applied. After introducing the catheter to the sufficient length, you can release this pressure and then suck the contents. So these are again other various sizes of this type of pressure control suction catheters with a color code, and also there is a stopper. So whenever not in use, you can put this stopper and close that so that it will not do a continuous suctioning. Okay, pressure control with the cap. What is this? Very commonly seen in your OTs.
Yonker, sir.
Yankers, very good. Yanker plastic suction tip and tube. Okay, this will come as a sterile unit in a sealed cover. This is supposed to be disposable. So this is the yanker. Why it is bent like this? That is a common question examiners will ask you. If you see the yanker tube, all of you would have had the experience of using it. It is not a straight tube. It has got an angulation. Why is it angled like that?
According to tongue and
It fits
oropharynx.
into the oral anatomy.
Not the oral anatomy. You can
To avoid
visualize
injury.
the tip all the time, okay? Because it is bent, it has an angulation. You can see exactly where the tip is going and sucking. If you have a straight tube, your vision will not be able to see the tip. So all instruments which are used with an angle are meant because you can see sometimes the forceps used by the ENT surgeons for packing the nose, which is called the bayonet forceps, where it is angulated like your gun bayonet. Okay, so that angulation makes it you to visualize the tip. Even in soldiers, when they use the long AK-47, you can find that there is an angulation. There is a shoulder support, then there is an angulation. If the gun has been made straight, they cannot visualize where the tip is. So that is the principle of any angulation. You can see the tip of the instrument and avoid injury to the delicate parts inside. What is this? Most of you
Closed
would have seen.
suction used for the ventilator patients.
Very good, very good. During COVID time, most of us would have used this because it doesn't let any contaminated material to come out or come in contact with us. So this is called the closed suction catheter, which can be introduced through the endotracheal tube without interrupting ventilation, number one, and at the same time without exposing the suction material to the operator. Okay, so that is the advantage of this suction. This is the control valve, and this will be attached to the ventilator circuit, and gases can still be going, and this plastic thing can be introduced inside suction, and this is the reservoir where it will be collected and you can dispose it off. Okay, so these are all the parts of this closed suction catheter. What is this?
Masks of different sizes.
Masks of different types. Any other answer? Always I told you, if you see the color, you must say it is all color coded.
Color-coded.
Color
Yes.
coded. Is it transparent or is it opaque?
Transparent.
Transparent. The
And
earlier masks which were designed during the developmental stages of anesthesia, what sort of masks they were? Were they transparent or opaque models?
opaque and black in color.
Black
Opaque
rubber.
and black in
Anti-static.
color. Yes.
So why
Anti-static
they
phase
have to
mask.
change it to this transparent color or the transparent design?
To visualize any secretions coming out from the patient's mouth.
Excellent. Not only secretions, or if an emergency full stomach patient, when you are anesthetizing, supposing patient regurgitates and vomits, in a black mask you cannot find out unless it flows out through the sides of the mask. Okay, so that is the reason why they have changed the original opaque black colored rubber mask into transparent, color coded, scented mask. Some of you, when you have used this mask for the first time, before it is attached and used to the patient, if you smell it, it will have a very pleasant smell. So these are all scented masks. Now, what is this for? What is this color coded rings? What is the purpose of these things?
Harness.
Harness, very good. It can be used for the harness to tie the mask to the face without the hassle of holding it. And what is this tube for? This opening?
It is
To inflate or
inflatable,
deflate
so it
mask.
provides adequate
This is the
seal
port for
around the
inflation.
face.
So it can the volume of air inside can be adjusted to suit the different types of faces. So if a patient has too much of a hollowness in the maxillary area, a old patient with the edentulous patient, if they come with a lot of depression in the maxillary area, you can inflate more air to make a good tight seal. Okay, so that is the purpose of air inflating port. This is the hooks for harness which can be used. I am going to show you the pictures later now. So inflatable, transparent, disposable, color coded mask. I should have added that color coded also here. So inflatable, transparent, color coded, disposable face mask. And this is the older model. The what I told you about the black rubber, and here also you have that metal ring with flanges here, and this is also the airport through which you can inflate to increase the volume here. This is the injection, air injection port for that. So this is a black rubber anatomical face mask. And what is this? Is there any specific name for this compared to this? What is the difference you find between this and this?
RBS mask with
There is no air injection port here, and there is no this ring with flanges are not there. So this is made for whom? It's mostly for pediatric use. So this is called Rendell-Baker-Susek mask. Okay, so these are the older types of masks used mainly for pediatric patients, where it produced a wide opening with least resistance for the child to breathe, and it had minimal dead space compared to the other anatomical face mask. The dead space, apparatus dead space, is very much reduced, and 3 people designed it, so all the 3 names have been clubbed together to call it as Rendell, Baker, and Susek mask. What is this? Just make a guess. There are 2 other openings apart from the ones for the normal attachment of the circuit. Here you have one closed lid, big lid closing one opening, and there is another long tube here.
Intubating mask, sir.
It's a transparent face mask for any scopy, not only intubation. You can do an endoscopy, upper GI endoscopy. You can do a fibroscopic bronchoscopy. So any scopy can be introduced through this, and this circuit will be attached here, so that you don't have to hold the mask close to the patient. Okay, so it can be used for scopies. And what is this?
Face mask
CPAP
for
mask.
NIV.
Maybe, sir.
This is
NIV.
for CPAP mask. So patients who are using CPAP machine, who are the patient recommended to use CPAP?
Patient with OSA, sir.
OSA patient.
Yeah, sleep apnea patient. Very good. Obstructive sleep apnea patients, they are advocated to use the CPAP machine. So their mask, this will be the headband. This is at this opening here close to the posterior side, the occipital area, and these straps are adjustable ones, and this is the inlet. So this mask will be a tight fitting. It covers both the nose and mouth. Some design is there where it will cover only the nose and not the mouth. So there are different types, and this is used as a CPAP mask. And the same design more or less is used for the harness also here. So you can have a strap which goes to the back of the head, and then you can hook onto it so that the mask will be well fitting to the face. And this is the harness that you use to hold the mask in position. Okay? So this will go to the posterior side, and you can see there are 4 straps which can be inserted here in that. So from 4 types you can pull it into the front and hook it on to this harness ring, and then keep the mask in place without your tiring your hands to hold it for a long time. What is this?
Venturi
Very
mask,
common.
sir.
Venturi mask.
Nebulizer
Very
mask.
good. Adjustable Venturi mask. Okay, so you can adjust. This is this. If you see that, you must immediately identify this is a Venturi mask. And what are all the various equipments that you are seeing here? Identify each one of them.
Non-rebreathing mask with reservoirs.
This one, is it?
Yes, sir. Yes, sir.
Very, NRBM. What is this?
Ambu bag with ambu mask, sir.
Bamboo bag with a face mask. Very good. This one,
That's a tight-fitting seal NIV mask.
CPAP. This is a CPAP
CPAP
mask which we saw. What is this one?
Nasal prongs.
Nasal prongs. This is
Nebulizer mask, sir.
Hudson mask.
laser mask. Very good. And what about this?
Hyperbaric oxygen chamber, sir.
Hyperbaric oxygen chamber. Very good. Ambu bag, CPAP mask. Second one. Nasal prongs. Third one. Face mask with reservoir, hyperbaric chamber, and Hudson's mask. Okay, so this is a simple Hudson's mask which can be used even for your stabilization. What is this equipment?
High flow nasal cannula, sir.
Fantastic.
High flow
nasal oxygen cannula. Very good, very good. So commonly used during COVID time. And what is this?
O2 concentrator.
Oxygen concentrator. Excellent. For domiciliary or home oxygen supply. Okay. And this is and there is a one-way valve, no rebreathing. So non-rebreathing mask, face mask. Okay. So this is the NRBM and the close-up view of that. Now identify the items shown here. What are these?
Color coded spinal needles of
Color-coded
various
spinal needles.
gauges.
Very good. Color-coded spinal needles. These are the various tips. Of course, we have the Winky, Whitaker, Sprout, and Green. So what is this Whitaker called? Other name for this Whitaker needle?
Pencil
Dura
point needle.
splitting.
Dura splitting needles.
It's a pencil
Pencil.
point needle. It is almost looking like a pencil which is sharpened. And the opening is little away from the tip. It is not in the tip like the Quinky and the green tip. Okay, so Quinky and green have the beveled opening at the tip of the needle, whereas the Whitaker and Sprout needles have the opening a small little distance away from the tip of the needle, so that they don't tear the fibers of the dura, rather than they separate the fibers and go inside. So there is a lesser chance of why they have made it like this, to separate the fibers and not tear it. What is the advantage?
To decrease the incidence of PDPH, sir.
PDPH, very good. So the leak of CSF will be very much minimal because the fibers will immediately close and the chances of PDPH is very much reduced. Very good. And what is this?
It is a
Our T should be
CSC kit,
quite-
a combined
Combined
spinal
spinal
epidural.
with epidural.
Combined spinal epidural set. So you can see this is a 2E needle. This is the spinal needle to identify the CSF. This is the loss of resistance syringe. This is the filter. This is the catheter, epidural catheter, which you have to thread. Okay, good. What is this?
2E needle, sir. For epidural.
Just a 2P needle or distance marked 2P needle. Okay. Earlier
marked.
2P needles were metal needles without markings. Now this is a 2P needle with marking so that you can identify the distance. And what is this? When you want to give continuous post-op epidural analgesia,
The patient controlled.
patient controlled What is this? This is a reservoir for local anesthetic.
Baxter, sir? Baxter. infusion.
Baxter elastomeric pump. Okay, this is an elastomeric infusion pump. So what you see in the inside of this bottle, this is a small rubber bag inside. So as you put the local anesthetic for 24 hours, you can calculate and fill it up. The whole, this will swell like a balloon and gradually release that at the setting that we keep, and always give a continuous flow of local anesthetic without interruption, and patient will have excellent post-operative analgesia. So this is called the elastomeric infusion pump, which is very easy to operate without any complication. What is this instrument?
Peripheral nerve stimulator, sir.
Nerve
Peripheral
stimulator.
nerve
Very good.
stimulator.
So here is a peripheral nerve stimulator for nerve block. Why I say it is used only for nerve block and not to monitor the neuromuscular junction as you do during general anesthesia? What makes you identify that it's a peripheral nerve stimulator? It should be used when you are giving a, say, plexus block or a nerve block, femoral nerve, sciatic nerve, popliteal nerve block. What is one indication that this is the thing used for that? What is the current strength here?
5 amperes.
5
5
milliamperes.
amperes.
5 amperes. 5 amperes. So this is the maximum current it can give. So the nerve stimulator used for giving a nerve block or a plexus block should not have ability to produce a current more than 5 amperes. Okay, otherwise it will be very painful. So it will start from 0.1 and go on in increments of 0.1, 0.2, 0.3 like that up to maximum 5. So at what strength you should start attaching this and trying to locate the nerve? When you start, how do you use this for identifying a nerve and blocking it? What is the technique of doing it? What is the initial current you will use?
0.5 ampere.
0.5. Initially, you can use 2 milliamperes. Okay, 2 milliamperes, and then go near the nerve. As you go near the nerve, you have to reduce it and go up to 0.5. Reduce it to 0.5, so that till if you get good contraction, that means you are very close to the nerve. Then once you inject the local anesthetic, what should happen? The stimulation, should it stop or should it continue?
It will stop after
It will
giving
stop.
local anesthetic.
What are the reasons for the abolition of the stimulation or contraction of the muscle? Once a local anesthetic of, say, even 1 or 2 ml is injected, how does the contractions are abolished? Is it the entire nerve getting blocked, or is it some other reason?
Sensory impulses get blocked first.
Ah,
Before motor blockade occurs, sensory blockade occurs because those fibers
sensory
are
blockade
blocked.
occurs, yes. One is the action of the local anesthetic on the nerve. Second is the distance between the nerve and the needle tip is increased. When you inject the local anesthetic, the distance, the nerve is pushed away. So the distance increases, and also the local anesthetic acts on the nerve. These are the two reasons why immediately you will find the contractions getting abolished, and you can further inject the, what will happen if you are making an intraneural injection by using this needle? What will the patient complain of?
Shock-like sensation.
It will be a severe pain, burning pain will be there. So if patient complains of burning pain when you are injecting 1 or 2 ml test dose, you should immediately withdraw the needle a little bit. So in a correctly positioned needle, patient should not experience any pain while the local anesthetic is being injected. Okay? What is chronoxy and what is Rio base? These are two terminologies which are used in this sort of nerve stimulators used for nerve stimulation and nerve block.
The current.
So vario base is the lowest amount of current that is required for stimulating the nerve.
Chronoxy. Okay, right. You tell me in the next class. Read about it and tell me. I will not give the answer now. So this is a little different from that. You can see here there is a strength of 40 milliamperes here. So this is used for mostly monitoring the neuromuscular junction. So peripheral nerve stimulator for monitoring neuromuscular junction has got a higher percentage of strength of current that can be delivered, and it is usually attached to the thumb for eliciting the stimulation. So how does it differ from one shown in the left? That is the current strength mainly. And can this be used for blocking the nerve, like the first picture? Here you can see there is a pulse, the battery indicator, there is a train of 4, there is a tetanus. So when all these modes are there, can this be used for blocking a nerve or a plexus?
No, sir.
No, it should not be used, because the minimal current supplied by this sort of nerve stimulators will be 10 milliamperes. Okay, so what we require is less than 5 milliamperes for the identification and blocking of a nerve, whereas only for the stimulating the neuromuscular junction we need a higher strength of current. So all the instruments which have this strain of 4, twitch and tetanus, their double burst DBS, all these things are mainly for monitoring the neuromuscular junction. Okay. What is shown here and what are the displays that you see in this?
Pulse oximeters.
What type
Portable
of pulse
pulse
oximeter?
oximeter.
Portable finger probe pulse oximeter. Very good. So what are all the displays that you are seeing here?
Peripheral saturation, pulse rate, pulse index,
Hmm.
respiratory rate.
Then what is this? Plethysmographic tracing. What is PVI and what is PI? This
P is
is
pulse
right?
index.
What is PVI? PI is perfusion index. This is peripheral volume index, respiratory rate, battery sense whether it is full or not, and there is a Bluetooth signal, and there is a word written Massimo. What does this Massimo stand for? It's a finger probe pulse oximeter. Okay, it displays SpO2, that is oxygen saturation, PR pulse rate, plethysmograph tracing, battery charge indicator, and a Bluetooth connection, respiratory rate from plethysmograph, pleth variability index, and perfusion index. So all these things are shown here. And what is PVI used for? That is pleth variability index. What is the what does it indicate? It helps to assess the strength of peripheral circulation. Okay, so normal PVA is about 20 to 40. So if it is in that range, you will have that means the peripheral circulation is quite strong. And this Massimo is a name of the American company making non-invasive monitoring equipment. And they use a technology called signal extraction technology, SET, signal extraction technology, which removes artifacts and motion-induced changes and gives you the correct reading. So these are the people who first introduced. Earlier pulse oximeters, when they are attached to the patient, if the patient's finger moved, the readings were distorted. Or when the patient had a very cold extremity and the circulation was very poor, it could not read the saturation. So all those things were eliminated, and you will get a constant display of the saturation and a plethysmograph display by using this technology, which is called signal extraction technology. Okay, So that is the answer for that. What is shown here? You read carefully. It
Checklist.
starts from so many things. Intravenous bag, volume, drip chamber, operating
Intra
table.
monitoring.
Complete closed loop monitoring. This is called closed loop monitoring, where you monitor everything of the patient, including the surgical field and surgeons, urobag, anesthesia monitor, airway devices. So this is called the closed loop monitoring. So what is meant by closed loop monitoring? It is the method to ensure comprehensive monitoring of the patient at regular intervals. Okay, so you can use all these things A, B, C, D, F, G, L. And how is this achieved? It is achieved by closed loop visual inspection of the patient, anesthesia machine, standard monitors, and surgical field at regular intervals in a predetermined sequence so that none of the parameters are missed. So this will be the future thing for us to keep a constant vigilance monitoring of the patient. And the main source is as follows: the patient, clinical assessment, pulse, airway, chest movements, intravenous lines, rate and amount of fluid infusion, urine output, surgical field. The monitor component is the anesthesia workstation, which gives you all about that. Operating table and patient record, and back to the patient. So that is why it is called the closed loop patient. So once you identify the parameters, immediately the corrective actions are also suggested. So you have a constant vigilance on the patient and correct whatever physiological aberrations happen and immediately take care of them so that you can provide the most safest anesthesia. Okay, so that closes the asking questions or equipments. And this is visible now, the next part?
Yes, sir.
Yes,
Visible.
sir.
Okay,
Yes, sir.
very good, very good. So we will now go to the vaporizers, which is also important for both the juniors as well as seniors. And the first picture, oldest picture, what is being shown here? What are the names of the Schimmelbusch mask? What else are they using? Only Schimmelbusch mask? Something?
A cloth over that.
No, I'm not able to clearly hear you.
Chloroform.
Chloroform or ether, we don't know whatever he is using, but he is using a bottle. Can you name the bottle? Anybody able
Amber
to say?
colored bottle, sir.
Amber. Why amber colored bottle? Now that you have mentioned amber colored bottle, why
The
you
volatile
have to
agent
use?
is photosensitive, sir.
They will be the agent that you use may be degraded by the sunlight. So amber colored bottles prevent the entry of ultraviolet rays and then degradation of the contents. So amber colored bottle. So it is called the Schimmelbusch mask. This white mask what he is holding is the Schimmelbusch mask. And the bottle that he is using, you can see this in a close picture. There are two openings. What is the purpose of this? And you can see some drops pouring out through only one opening. So what is the purpose of the other tube that is being inserted here?
The negative pressure created is usually
Not negative pressure,
caused by
to suck the
air.
atmospheric air into the
Atmospheric air.
bottle so that there will be a constant flow. Otherwise, what will happen in a tightly closed bottle, if you have only one tube, it will flow a few minutes, then stop. But if you have the second tube, then air will enter and go inside, push the bottle, the liquid inside, and constant flow will be there. And that is called the Bellamy-Gardner bottle. This bottle is called the Bellamy-Gardner bottle, and the mask is called the Schimmelbusch mask. So this is the design of that Bellamy-Gardner. This is a rubber stopper. This is an amber colored bottle, and you have one tube for the outlet and one tube for air entrainment. Okay, so this is called the Bellamy-Gardner bottle. Under what type of anesthesia circuit this is classified?
Open circuit.
Open drop method. Very good. What are the features of open drop method?
It doesn't have a scavenging system.
Scavenging and all came very, very late. Do you have a carrier gas for this inhaled anesthetic to go? Like your machines giving you oxygen, nitrous oxide, do you have any carrier gas to carry the vapor into the patient?
No, sir.
Then how does it go?
Whatever the
lung?
patient breathes,
So the carrier gas is the atmospheric air. So patient is open to the atmosphere. He breathes in from the atmosphere and breathes out to the atmosphere. That is why it is called open method of anesthesia. There are no separate carrier gases supplied. Patient's airway is open to atmosphere as he breathes from the atmosphere and breathes back into the atmosphere. And the volatile agent is vaporized by the atmospheric air by patient's own respiration. Okay, that is why. And why this Schimmelbusch mask is having such a thick covering of gas pills? How many layers? Common exam question, especially even though it is now become very, very obsolete and historical. Examiners are fond of asking some history questions. So how many layers of gas piece will be there in that Schimmelbusch mask? What is the ideal number of layers? What will happen if you have too limited number of layers and if you have too many thick layers? These are the common questions they may ask you. Sometimes if you do extremely well and you have to get the university rank first mark, this question may be asked to you. Normally,
4 layers.
4 to 6 layers of gas. Okay, normally 4 to 6 layers of gas, because the gas is a interwoven with a gap. It is not a cloth like your dress material. It is a lot of gap in between, the crisscrossing. So it increases the evaporation surface. That is the idea of using this gas piece and not the regular dress like material with a tight woven cloth material. So this gas piece 4 to 6 layers are supposed to increase the surface area for evaporation and produce more amount of vapor. And if you use too much, 12 to 15 layers of gas, then it becomes a resistance to breathing, because they will not allow the patient to take in the atmospheric air easily. And if you have too limited number of gas layers, like say only 2 layers, then the amount of surface available for vaporization will be very much reduced and the induction will take a long time. Okay, so that is the answer for this. How many ideal layers of gas should be there in the Schimmelbusch mask? 4 to 6. Less than that, less evaporation. More than that, more resistance to breathing. Okay, so that is the answer that you have to give. Now name these things shown here. Again, these are all museum questions, obsolete questions.
Goldman bottle, sir.
Pardon?
Goldman.
Mapleson.
No, sir. Goldman.
Goldman is not this.
Vaporizing chamber.
There's a particular name for this based on the person who invented the machine. It's a clue I can give you. Who is the person who invented anesthesia machine which we talked in the last class?
Boyle, sir.
So Boyle's apparatus, no? That Boyle only introduced this bottle, simple bottle. So it is called Boyle's bottle, both of them. One is for ether, another is for an agent called trilene, trichloroethylene or trilene. Okay. Now, why this bottle is bigger and why this bottle is smaller?
Trilene is very potent.
Excellent, very good. So any agent which is very potent you should have a smaller reservoir so that you don't give too large a concentration and produce a very deep depression in the patient. So comparatively, trilene is a much more stronger potent agent compared to ether. And ether, you know what is the adage or the saying that we used to say in those days? An average anesthetist with average skill cannot kill a patient with ether. An average anesthetist with average skill, he cannot kill or she cannot kill a patient with ether. So however much you pour ether, patient may remain unconscious for a long time, but it is very difficult to kill a patient. So that is the safety of ether. So it is maximum you can pour up to 300 ml. You can see the marking here, whereas here it is hardly less than 100 ml. And the various parts, of course, they may not ask you, but just looking at it, can you say what is this may be for?
Pressure relief.
This is a cork stopper, which you can remove and you can fill the bottle through this. So this is a stopper for filling and closing the bottle on both these things. And what is this for? There's a rod projecting and it is written off. Then there are markings here, both of them. So what, make a guess what it could be.
Switching on and off of the vapor.
It is a control lever. It's called the control lever to allow the fresh gas flow into the vaporizer. Okay, and there are no specific percentage like what you get in your present day vaporizers, like 0.1, 0.2, 0.5, 1, 2%, 3%, 5%. And for desflurane, what is the maximum percent you have in your modern vaporizer? All of you are using desflurane nowadays. What is the maximum percentage of vapor you can deliver from a desflurane vaporizer?
12%.
18%. Okay, go and check your
18.
vaporizer tomorrow. Okay, so this is the control lever where arbitrarily there is a first position, second position, and a maximum position. Okay, so whatever the opening, what is the concentration coming out, nothing is known. It is an arbitrary measurement that is being done here. So what are the parts of the vaporizer? This is the picture. It will tell you about it. So there is a inlet. This is a gas inlet tube from the flow meter. It will come, and this is the lever activating, drum activating lever or a control lever. And the name of the agent is written here. And this is the stopper, as I told you. It is attached with a chain so that it doesn't fall off. And this is a operating plunger. So when you press this plunger, the whole thing, this is called the cowl. The whole thing will go inside and gases. So they may ask you what type of vaporizer this is. What is the method of vaporization that is happening in this? The fresh gas flow will have to come inside through the inlet, come into the bottle, and it can just carry the vapor from the top of the liquid. Then that is called
Overflow.
flow over, not overflow. It is called flow over method of vaporization. Okay, don't reverse that answer. Overflow means that is overflowing. The flow over, the gas flows over the top of the liquid and then carries the vapor. That's called flow over method. But when you press this plunger, what will happen? The gas will go underneath the top surface layer of the liquid and bubble through this, come out as small bubbles and then carry more vapor. That is called bubble through vaporization. So there are two methods of vaporization in this bottle. One is called the flow over vaporization when the plunger is in the position. When the plunger is immersed into the liquid, then it converts itself into what is called bubble through vaporizer, where more amount of vapor can be carried because of the small bubbles having a larger surface area. Okay, so whenever you want to induce a patient faster, you have to use the bubble through method. Whenever you want to induce a patient slowly, you can use the flow over vaporizer. Okay, flow over technique of vaporization. So these are all the parts. Can you name this apparatus? It was also an offshoot from this. After the Boyle's machine and Boyle bottle were incorporated, the Oxford University manufactured this. And the name for this is available in this picture itself. If you have read about the history of anesthesia, you will be able to answer this.
So draw over a type of
Draw over is the
resistant
mechanism.
paper.
It's written here. But what is the name? The name, the clue is in the picture itself.
Oxford miniature vaporizer, sir.
The Oxford miniature vaporizer is only this part. This is the clue. This is the name of the apparatus. What is the expansion for this? This is an acronym. It is called Epstein Macintosh Oxford vaporizer. Okay, EMO. It's also called EMO vaporizer. Epstein is one person, Macintosh is another person, and Oxford is the university where they developed this machine. So it is called EMO vaporizer, otherwise known as Epstein Macintosh Oxford University vaporizer. Okay, this is a draw over vaporizer where there is a ether will be used in this, and the bellows will be used as pumping gases instead of reservoir bag, and draw over. It will draw the vapor from the machine and mix it with either oxygen or air. You can supplement oxygen compared to the other machines, and it can be delivered either through the mask or attached to the endotracheal tube, and you can do ventilation, maintain anesthesia for any number of hours. Mainly, they developed this for the battlefield. When Second World War and First World War injuries victims were there, they have to do some emergency procedures in the battlefield itself. So to give anesthesia in the battlefield, this is a portable equipment, so they carried it, and you can use it with the atmospheric air as well as supplemental oxygen, and they can just hold the mask and give anesthesia for victims who needed an emergency amputation or a removal of a bullet from an injured part of the body. So this is mainly developed for that. So Epstein Macintosh Oxford vaporizer. And what is this? Somebody made a name for this. Whoever said that? Who answered Goldman for this?
Sir, me, sir.
So this is the Goldman vaporizer. Okay, this is called the Goldman vaporizer, which is a removable, detachable vaporizer. It can be fixed inside the circuit as well as outside the circuit. Okay, and it was mainly introduced when halothane came into clinical practice, and maximum you can pour is 30 ml. Beyond that, it will be more toxic, and it has got an inlet and outlet, and this is the control lever. Again, it is an arbitrary marking. There is no exact percentage how much vapor will be delivered, and you have off position and on position. So one common question in those days the examiners used to ask is, supposing you have only 30 ml of halothane and you have to do a surgery for say 2 hours, how will you use Goldman vaporizer and give anesthesia? The answer for that is you have to use it inside the circuit. Vaporizer inside the circuit, where you fix this. This is as I told you, it is a detachable vaporizer. It can be fixed into the inspiratory limb of the circuit system, and you can use the first division or the lowest concentration, because the gases will go back and come in circle. You will get the same percentage. Of course, we do not know exactly how much percentage is being delivered, but with a small amount, it can be used at a very low concentration or the dial setting and deliver the gases. So by using this Goldman vaporizer inside the circuit, in the inspiratory limb of the circle system, you can anesthetize the patient with a very small volume of halothane if you don't have enough stock. Okay, that is the answer for that. That's a common question. I don't know whether the present day examiners know about this. In case somebody who is smart enough to ask this question, be prepared for that. Now, few terms you have to understand to know how the vaporizers work. This is the first answer is you must know what is the difference between a gas and vapor. Can anyone answer this question?
Gas is a state of substance above, it is present above its critical temperature.
Temperature and cannot be compressed back into a liquid. Okay, so that is,
Yes.
whereas vapor, by applying pressure, you can, it is a gaseous form. It is not a liquid form, it is a gaseous form, but it can be compressed back into a liquid. Okay, so vapor arises from a liquid evaporation, whereas gas in a gaseous state above the critical temperature, and it cannot be compressed into a liquid. Okay, that is the main difference that you have to know. Then the next thing is saturated vapor pressure. What do you mean by saturated vapor pressure?
However, the pressure is applied above which the vaporization is not possible.
Vaporization is not
The
possible.
amount of evaporation and condensation is equal at that amount of pressure, sir.
Evaporation and condensation. Okay. So is it taking place in a closed container or open container?
Closed container.
Closed
All
container,
these
sir.
things are related to closed container. In a closed container, when a liquid cannot become a vapor anymore, and both the vapor state and the liquid state are in equilibrium, that is called the saturated vapor pressure. Okay, in a closed container, when the vapor and the liquid are in equilibrium and no more vaporization can occur, that is called the saturated vapor. No, all the maximum amount of vapor formation has taken place. No more vapor can be formed. Okay, that is called the saturated vapor pressure. Why? You have to know that this saturated vapor pressure, what is the importance of that? Okay, I will show you why that. What is the next point? Boiling point. What is the definition of a boiling point? Boiling point of a liquid. These are all some physics questions which will be definitely asked in the examination. Boiling point is there for a liquid, isn't it?
Yes,
When
sir.
you boil water, what happens? All of you have that experience of boiling water for making
The
your
temperature
coffee.
required to convert the liquid to gas.
Even at a smaller temperature, it will start forming the vapor form. Boiling point is defined as the temperature at which the vapor pressure of the liquid equals the atmospheric pressure. That is the definition. Okay. So when the water starts boiling at 100 degrees centigrade, we say it is the boiling point of water. At that time, even at 70 degrees, 60 degrees, you will find that there are small bubbles formed in the water which you are boiling, isn't it? All of you would have noticed that. But only when it reaches 100 degrees, the whole water bubbles very violently and a lot of steam is coming out. So the boiling point of any liquid is defined as the vapor pressure when it equals the atmospheric pressure of the ambient room or the ambient place. That temperature is called the boiling point. And this is important because when you use a vaporizer at a higher altitude, what will be the ambient temperature at the high altitude? Supposing you use a vaporizer at Ooty or Kodaikanal, do you have the same 760 millimeters of mercury pressure as you have in Chennai?
No, sir. As the temperature will
So
start decreasing,
boiling
pressure.
point will decrease, isn't it? Because the vapor pressure will equalize. Supposing Ooty or Kodaikanal has got an ambient pressure of only 710 millimeters of mercury. So at that temperature, that pressure itself, the vapor pressure will become equal. So the boiling point will be very much reduced at a higher altitude. So that is the reason for the correlation between the vapor pressure and the ambient pressure. This is the boiling point. The temperature at which the vapor pressure becomes equal to the atmospheric or ambient pressure is called the boiling point. So how will you calculate the gas concentration for which only you require this saturated vapor pressure. So the saturated vapor pressure of any liquid divided by the ambient pressure is called the, you will get the gas concentration. For example, for thiofluorine, the saturated vapor pressure is 20.1 bars, and the atmospheric pressure is supposed to be 100 bar. Okay, so 20 divided by 100 multiplied by 100 per percentage, it gives you 20.1% of thiofluorine. So can you use thiofluorine like what you did for ether or chloroform by open drop method?
No, sir.
No, then you will give 20.1% of thiofluorine, and that is the reason why we require a vaporizer. So the modern liquid anesthetic agents, they are all very, very potent agents, and their saturated vapor pressure, when it is used in the normal atmosphere as a open drop method, they will deliver a very, very high concentration which will be lethal and produce mortality. So that is the reason why we use a vaporizer to give a corrected, small, clinically safe concentration of vapor. Then splitting ratio. What does the splitting ratio mean?
It's used in the variable bypass.
Very good. So all the gases that are delivered from the flow meter, if you whether you use oxygen air or oxygen nitrous oxide, whatever mixture you are using, that is called the fresh gas flow. That fresh gas flow sometimes may completely not go to the vaporizer at all when the vaporizer is in off position. If you don't switch on the vaporizer, the entire fresh gas flow will go through what is called a bypass channel and straight away come out to the patient end, to the common gas outlet. On the contrary, when you want to anesthetize the patient and keep him unconscious, then you start using the vaporizer, keeping it at say 2%, 1%, 0.5%, depending upon the depth of anesthesia that you want to maintain. Then what happens? The fresh gas flow coming from the flow meter, part of it will go into the vaporizer, pick up the vapor of the agent, and then come and join at the outlet level with the fresh gas flow that is coming in. So you can vary the percentage of fresh gas flow entering the vaporizing chamber or avoiding vaporizing chamber and going straight by a bypass channel. So this is called the splitting ratio. How much of fresh gas you are splitting between the vaporizing chamber and the bypass channel, that is called the splitting ratio. So higher the splitting ratio, where you allow more amount of gases to go into the vaporizing chamber, you will get a higher concentration. If you allow a lesser percentage of gases to go into the vaporizing chamber, you will have a lesser concentration. So that is the main importance of splitting ratio to adjust the concentration. And again, this variable bypass is nothing but the ability to vary the amount of gases going between the vaporizing chamber and the bypass channel. And what is the measured flow indicate, or what is the meaning of that measured flow? One vaporizer which you are using in the modern day is a measured flow vaporizer. Which one is that?
Desflurane.
Desflurane, yes. Why is so much of hesitation? Desflurane vaporizer is a measured flow where the fresh gas flow does not totally enter into the vaporizing chamber. All other thiofluorine vaporizer, isofluorine vaporizer, halogen vaporizer, enfluorine vaporizer, in all these vaporizers, part of the fresh gas flow or even the entire fresh gas flow can be made to go into the vaporizing chamber and pick up the vapor and come and deliver it at the patient end. On the contrary, in desflurane vaporizer, no part of the fresh gas flow enters the vaporizing chamber. Instead of that, the vaporizing chamber which is holding the desflurane liquid is heated by a heating element, a pressure is built up with the vapor inside, and that pressurized vapor is made to come and mix with the fresh gas flow. So that is a measured flow of the created vapor allowed to come and mix with the fresh gas flow. Okay, so that is the mechanism of desflurane. Whereas in all the other vaporizers, the fresh gas flow itself causes the vaporization and picks up the vapor. Whereas here, a separate heating element and a separate holder for the liquid desflurane makes the vapor by heating that liquid, creating a vapor under pressure, which can be delivered into the passage of fresh gas flow. Of course, pictures are there later for you to understand that point easily. What is latent heat of vaporization? This is another terminology which you should know.
To maintain constant temperature in the vaporizer, which affects the output.
What is the meaning of the word latent? Latent means hidden. Hidden heat of vaporization. Okay, the opposite of latent is overt, what is seen outside. So the word latent means it's there. Where is the heat hidden? The heat is hidden in the metal that is making the vaporizer. Okay, all the metals, they can have some amount of heat in them. So that heat is supplied to the liquid for it to vaporize, and there is a specific heat at which things vaporize. And third is the third terminology called thermal conductivity. How the metal out of which you are making the vaporizer can absorb heat and conduct it or resist the heat being applied to that. Okay, so these three are related to the material out of which the vaporizers are made. The latent heat of vaporization to supply the heat to the liquid, specific heat at a particular heat where it can convert the liquid into vapor, and the thermal conductivity where the material can absorb and spread the heat that is there. So these are three terminologies which is relation to the construction of a vaporizer. Okay. So the common question they may ask you is, how are vaporizers classified? This can be a question in the theory paper also. So how do you classify the vaporizers?
Based on 6 things, sir.
There are different ways of classifying based on the functional status and mode of action. So it is not a single classification. So the first method is vaporization method. As I told you earlier, maybe a draw over or a flow over vaporizer, or a bubble through in the boil bottle, or with without wicks, or injector type. These are all the various methods of vaporization. Then regulation of output concentration, either by bypass, variable bypass, or measured flow, which I told you again. And third is temperature compensation, whether there is an automatic temperature compensation or you have to give a supplied heat, or manual thermocompensation, or no temperature compensation. The boil bottle and the trilene bottle I told you, there is no temperature compensation. When the outside temperature of the bottle drops, because it takes the heat from the atmospheric air surrounding that, whenever you use the boil bottle, after some time you will find water droplets forming on the outside of the bottle, because the water vapor in the air that is surrounding the bottle, that will provide the temperature for the vaporization, and the water will condense, and there, that is why we used to call the boil bottle is sweating by working hard, because of the water vapor it forms outside. And nowadays we have electronic temperature compensation methods where the accurate, so the tech terminology, the modern vaporizers are called TEC, Tech 1, Tech 2, Tech 3, which means temperature compensated vaporizers. So that short form acronym TEC stands for temperature compensation. And the fourth method is agent specific or multiple agents, whether you have to use only one agent. In the older bottle, people can mistakenly fill both trilene as well as ether or chloroform in any of the bottles. There is no restriction. Whereas nowadays you have to color coding is there, and you can use only a specific agent. And the common question examiners will ask you is, can you use isoflurane in a halothane vaporizer? That is the common question. Can you answer that?
No, sir.
All the modern vaporizers are all agent specific because they are constructed based on the
Saturated vapor.
saturated vapor pressure of that particular agent. So it will deliver a wrong concentration if you try to fill it up with a agent not meant for that particular vaporizer, not meant for that agent. Then the other thing is plenum or draw over type of vaporizer. And lastly, the location of the vaporizer, whether it is inside the circuit or outside the circuit. So these are the 6 methods of classification of vaporizers. And of course, again, this is with the example method of regulating outflow. You have ether vaporizer or tech vaporizer. That is, you can adjust the bypass level by the lever. And measured flow is copper kettle or vernitol. Method of vaporization is Goldman bottle as well as the ether bottle or boil bottle. All these are flow over. The ether bottle has bubble through, and desflurane is called the injection type. And location, you can use the Goldman, as I told you, inside the circuit. Outside the circuit, or most of the modern vaporizers we are using them only outside the breathing circuit, not within the breathing circuit. That is in flow with the flow meter. And the temperature compensation is done by either supplied heat or altered flow. And agent specificity. Nowadays, most of the vaporizers are agent specific. And Goldman you can use for multiple agents also. And resistance type is plenum as well as draw over. So this is the classification that is done. Now, what is the difference between boiling and evaporation? Are they both same or different? It's another basic fundamental point all of you should know.
Evaporation is a surface phenomenon.
And doesn't require any external applied energy. Okay, whereas boiling, you need a stove or a
Heat source.
to heat source. Okay, so boiling, evaporation occurs. In evaporation, spontaneously occurs at all temperatures from the surface of the liquid. Whereas boiling occurs when extra kinetic energy is added and at only one temperature dependent on the pressure, it takes place within the body of the liquid. So boiling, you can see the bubbles form inside. Whereas evaporation goes without our noticing. Gradually it will evaporate. And what is vapor pressure? Is the pressure of the vapor at equilibrium in a closed container is called the vapor pressure, and it is fully saturated, it becomes saturated vapor pressure. Okay. And what is the significance of vapor pressure is to predict the boiling points, create phase diagrams, and determine chemical stability. So this is the importance of vapor pressure. And among these things, there are vapor pressure given at 20, halothane, enflurane, ceoflurane, isoflurane, desflurane, which is highly volatile.
Desflurane, sir.
Desflurane, you can see the vapor pressure is so high at 20 degrees. Okay, so the maximum vapor pressure attained at 20 degrees is 669. So this is the most volatile liquid. Okay, and you can see here also this graph showing temperature. The diethyl ether is able to vaporize and go up to reach the vapor pressure of atmospheric pressure at a very low temperature. That is why it was used for open drop. Immediately it can become a vapor even though it is stored as a liquid. And then later chloroform and the carbon tetrachloride were all used. Okay, so the vapor pressure is important. These are some of the vaporizers which you are seeing in the modern days. Can you identify them? Because they are all different company models, so I don't expect you to know the individual name. Anyway, the A is what is called Tech 5 vaporizers, and B shows Tech 7 vaporizers, and the C shows Vapor 2000 by Draeger company, and this is Sigma Delta Penlon company. So these are all different brands or varieties of the vaporizer. Identify the vaporizers shown here. Sometimes the examiners are very fond of asking, comparing between the oldest Tech 2, Tech 3, Tech 4, like that. They may ask you the differences between these various models. So this is, can you make a guess whether it is Tech 2 or Tech 3 or Tech 4? It is written here in museum in anesthesia, so that must be quite old. This is a Tech 2 vaporizer for halogen. Okay, so all of you are seeing your modern vaporizers in your workstation every day. Can you just identify what are all the differences you notice in this machine compared to the ones that you are using? Observation skill. This is a test for your observation skill. How is the control lever, control dial setting here? Is it on the top of the vaporizer or facing the vaporizer? You are
Facing the
so this is a very old method. So they were having the control dial projecting like this. What about this port?
filling of
This is the filling port. Yeah, you can unscrew this thread and then pour the liquid in there. What is this? What is the name for this part of the? This is more or less present in all our modern day vaporizers also in a different form. What does it show? It's a transparent glass.
the level of
For the liquid, you want to know what is the level that you have filled. Okay, so this is called the sighting glass. SIGHTING, sighting. You are able to sight the level of the liquid. So this is called the sighting glass for assessing the level of the liquid, how much you have filled in. And this is a little bit improved version than that. You can see the dial here and see the dial here. It has gone on to the top of the vaporizer. And again, the filling port also has changed. The sighting glass is the same. So this is Tech 3 vaporizer for halothane. So this is Tech 2, Tech 3, and again this has got more or less similar features, but again it is agent specific, and there is a small change made in that. So this is also Tech 3 for isoflurane, and these are called the Somni 3 funnel fill vaporizer. So these are funnel fill vaporizer for isoflurane and sevoflurane. Then what are the methods of filling the modern Tech vaporizers? What are the different methods by which you can fill the liquid into the vaporizer?
key fill.
This is called the pour fill. You just remove the stopper there and then directly pour the liquid into the vaporizer. That is called the pour fill. This is a key fill. There is a particular type of pin which is introduced. Again, same for sevoflurane. This is the later version where you use a key type to fill that. The third is called the quick fill, where there is a cap attached to that which you can press inside and then fill the whole vaporizer. So there are three different methods of filling. One is pour fill, key fill, and quick fill. What is this?
The
Aladdin
Aladdin
cassette, sir.
cassette.
Aladdin. Very good. All of you seem to be very up to date and excellent. So here is the, what are the advantages of this Aladdin vaporizer? This is the cassette only. This is not the entire vaporizer. What is the mechanism of this Aladdin vaporizer?
The
It's a
electronically controlled, sir, and
Yes, it has got
magnetically coded.
coded. Very good. Aladdin cassette vaporizers regulate anesthetic vapor with the electro-pneumatic proportional flow valves. So there is an electronic component, there is a pneumatic component. So you can combine both and say it's an electro-pneumatic proportional flow valve controlled by microprocessors. So it is computerized. Though very different in external appearance, they are functionally similar to conventional vaporizers with a bypass chamber and a vaporizing chamber. So whatever method of vaporization happens here is partly there also. The variable bypass mechanism is also incorporated, and a single electronic control system installed in the main working station that is used for all volatile agents, including dust fluorine. Okay, so that is the advantage. It's a multi-agent cassettes which can be used, but the central processing unit is the main important thing for doing this. So what is the mode of operation of Aladdin? It has got two parts. One is electronic control and the portable cassette. And the electronic control mechanism is in the anesthesia machine. The portable cassette is one which you can remove and fit according to the agent that you want to use. So each cassette is nothing but a liquid sum with a control mechanism, and it can be tipped. You can tip it upside down, and it is maintenance free. And it can deliver the volatile agent in the absence of mains power with battery backup or adequate oxygen pressure. Okay? They are functionally similar to conventional variable bypass vaporizers. So what is the maximum volume of agent it can hold? That is Aladdin cassette vaporizer. What is the maximum it can hold? When is the volume when the ball in the side tube goes to the bottom? At what volume? The volume, and there is a, just like the bobbin that is going in the flow meter, there is a ball to show the level of the liquid in the cassette. What is the maximum volume you can fill this cassette with? 250 ml.
250
and
ml.
full.
250 ml.
Okay, and when the ball in the side tube is at the bottom, still there is 80 ml of the agent present in that. The safety features of Aladdin are when only 10% of the liquid remains in the cassette, an alarm message will appear so that it can tell you that you have to refill the cassette. Fresh gas flow in and out of cassette is electronically measured for enhanced control. When the cassette is removed, two spring-loaded valves automatically close the channels to and from the vaporizer so that there is no leak. In error situation, the valve operates to cut off anesthetic agent completely. And a pressure relief opens to the scavenging line if high pressure is detected in the cassette, or liquid level valve measuring the device detects overfilling. So both these conditions, it will automatically give a pressure venting outside. What is shown here and what is its working principle?
Dust fluorine vaporizer.
Very good. It's a
X6
text dust fluorine vaporizer. So this is the mechanism. You can see, as I told you here, this is a fresh gas flow coming from the flow meter. And you can see these blue dots are the fresh gases. They are going completely separately in a separate passage. And this is the vaporizing chamber. And this is the heating element. And the eosine colored dots are the vapors of dust fluorine. And they are only made to come and mix with this, with the fresh gas flow. So nowhere the fresh gas flow is going directly to vaporizer. Okay, so that is the mechanism, completely different from that. So this is the mechanism which it works, all these things. The parts of this are, first is the fresh gas flow tube, and this is the pipe through which it goes, all the fresh gas flow goes. And part 3 is the vaporizing chamber. This is heated by the electrical energy, and pressurized vapor is created here, and heating causes dust fluorine to become gas under pressure, and that is going to go through this chamber, and this travels down the pipeline separately. This is a pipeline for taking that, and these are two valves, one valve here, 6 and 13. Okay, 6 is the control dial where we set the delivery percentage of the dust fluorine. 13 is a electronically controlled, computerized control within the passage of this pressurized dust fluorine. So both these things only decide what amount of vapor has to come and join the fresh gas flow. Okay, and then this is the computer controlling the this valve here, and this is the desflurane delivery pipeline coming to mix with the fresh gas flow, and it meets the fresh gas flow at this point, and the final concentration emits outside outlet. The 2 is fixed by the resistance in the 10. So to alter and adjust the concentration, there is a resistor here in the fresh gas flow line also. So these are all the components of that which you are able to find out. Now, can you use isoflurane by open drop method? If the answer is no, why? Supposing the examiner asks you, can you use isoflurane? I have already given you an example in sevoflurane.
It is more potent than sevoflurane, so cannot be used.
Okay.
It
The
will
answer is no.
increase
Why? Because the saturated vapor pressure of isoflurane is 241. We saw for that it's 20 bars for CO. For iso in millimeters of mercury, it is 241 millimeters of mercury, and 760 millimeter is the ambient pressure, atmospheric pressure. So 241 divided by 760, you get roughly 33% of isoflurane, which is very, very high concentration, lethal concentration. So that is the reason. Always, whenever you are asked the question whether any agent can be used as by open method, you have to do this, know this formula. A saturated vapor pressure of that liquid divided by the ambient pressure, it will give you the percentage or concentration of the vapor that will be delivered to the person, and that should be within the safe limits. So what is the function of the vaporizer? It allows a determined safe concentration for the patient to be delivered. That is the main function of vaporizer. And define gas and vapor already we have done. Above critical temperature, it will remain as a gas. So however much you try to compress it, it cannot be made into a liquid. Whereas below the critical temperature, a vapor, when you compress, you can see it transformed a liquid. So this is the picture which will tell you about the difference between that. And so that definition is very important. Critical temperature is the temperature, of course, boiling point, all these things we have already discussed. And saturated vapor pressure is important for designing the vaporizer, because mentioning vapor pressure alone is meaningless. So vapor pressure increases with increases in temperature. So saturated vapor pressure of the agent mentioned along with the temperature, then only it becomes valid. So this is the most important factor of an anesthetic agent that decides the vaporizer design. Okay. And what are the safety advantages of tech vaporizers? The modern tech vaporizers, they have an interlock system to isolate the vaporizers when not in use. A clear indication of liquid level is there in there, which can be cited. No spill reservoir up to 180 degrees of allowable tilt. Earlier, when you tilt the vaporizer, the liquid anesthetic agent will come into the bypass chamber, and when you use it in the next patient, a very high concentration will come in the first few minutes. So that is prevented in the modern vaporizers by what is called the tilting mechanism, which will not allow the liquid to come into the bypass chamber. And the keyed fill or pore fill system to prevent using an incurrent agent, and an increased wick capacity to increase the concentration. So how to calculate the volume of liquid agent used? This is another formula that you should remember, both from exam point of view as well as supposing you go to a small nursing home later on after qualification. Sometimes the theatre sister will ask you, doctor, how much ml of CO or desflurane you have used? I want to send the bill to the pharmacy to calculate the theatre expenses. So what is the formula that you will use to find out how much volume in ml of liquid agents that you will be using for a particular surgery? Any idea? So there is a formula by these two people, Ehrenreich and Eisencraft. They formulated this in 1993. And the formula is whatever dial concentration. For example, if you are setting 2% sevoflurane, and if you are using a fresh gas flow of 2 liters per minute, then multiply it by 3. That means 2 into 2, 4.
Screen is not
multiply
visible.
by 3. Pardon?
Screen is not
You have stopped
visible.
sharing your screen, sir.
Stop sharing a screen.
Yes, sir.
Yeah.
Last two slides we were not able to see.
Okay, I assume somebody. Is it visible now?
Yes, sir.
Yes, sir, it's visible now.
Somebody's name appeared and then I think it got. Is it clear now?
Yes, sir.
So this up to this, were you able to see increased work capacity, advantages of
No, sir, even this slide
No, sir.
we missed.
Prior to this, sir. Prior to this.
Is it?
Tech 6 we were able to see, sir.
Huh?
We were able to see the slides up to Tech 6. Tech 6 vaporizer pods.
Now it is not seen.
It is
We have
seen.
seen, sir. We were able, you were sharing the slides up to Tech 6 vaporizer slide.
No, but this is the formula that I am now talking about.
Yes, sir. That is visible, sir. Now the slides are
Okay.
visible.
So remember this formula, dial percentage multiplied by fresh gas flow in liters in minute multiplied by 3. That will give you the total of liquid use per hour. So if you are doing a surgery for 3 hours using 2% sevoflurane and a fresh gas flow of 2 liters, then you will have to 12 into 3 hours will be 36 ml. Okay, so for every hour, this is the formula to use to find out the volume of liquid. And how to calculate the amount of vapor that can be formed from 1 ml of volatile agent? This is another question that can be asked. For this, you must use what is called the Avogadro's hypothesis. Avogadro's hypothesis says 22.4 or 22,400 multiplied by the density of the agent divided by the molecular weight. So for sevoflurane, 22.4 or 22,400 multiplied by 1.53 is the density and molecular weight is 200. Then you can say 1 ml of sevoflurane will produce 171.3 ml of vapor. Okay. So for that, you must know these two values, molecular weight as well as the density. Now identify the following. This is a picture of
Variable
a vaporizer. The fresh gas flow is coming here. This is a control dial, and this is the bypass chamber through which gases are going without picking up the vapor. Part of the fresh gas flow is coming into the vaporizing chamber using the splitting valve or splitting ratio, and it takes the vapor and comes out through the common. This is the inlet, this is the outlet. Okay, this is a common picture that is seen. Now here, what is this vaporizer?
Desflurate.
This is the
Fluorine.
desflurate. You can see the fresh gas flow going entirely without going into the vaporizing chamber, and the vapor is added by injection into this line. Okay, so this picture will clearly tell you what is the mechanism between the two. So this is variable bypass, this is measured flow. Now what is the difference between these two is what we have seen. Variable flow at various dial settings. So depending upon the dial setting, the amount of gas going through the bypass without picking up vapor and the amount of gas coming into the vaporizing chamber will differ. So if you see, you get only 1%. You can see the number of purple dots are less. When you keep the dial setting at 2 or 3%, you can see the number of purple dots are more. So depending upon the splitting valve, it goes. And if you so if you completely close, here you can see the dial is completely closed. So no fresh gas flow is going into the vaporizing chamber. and the entire gas going out is only the fresh gas flow without any volatile agent. So these are all the various positions which will give you an idea how the vapor dial setting is working. And these are the methods by which the vapor is picked up by the fresh gas flow. And when there is a high fresh gas flow, there is less time because the gases are traveling much faster. You have less time, so only little amount of gases, vapors are picked up. Whereas in low fresh gas flow, you have a lot of time, so more gases will be increased. And these are all the wicks which increase the surface area, just like the bubble through vaporizer producing a lot of bubbles to increase the surface area. The wicks also help to increase that. And again, bubble through also increases the vaporizer output. So for increasing the vapor output, you must have fresh gas flow which is not too high. You should have wicks and you should have bubble through mechanisms. And there can be supplied heat also, which will enhance the vaporizer to produce more vapor. And a metal made of good conductivity is important because when the temperature is low, the vaporization will be low. So if the metal out of which the vaporizer is made has got a ability to pick up the heat, then the amount of vapor formed will also be high. So if the metal allows the heat to dissipate, then it will supply that. And when it becomes cold, it reduces. Metal retains heat and metal donates heat. So the selection of the metal with which we make the vaporizer is important for proper vaporization. Effects of back pressure. This is another common question with regard to vaporizer, which you have a very good concept. So there are two effects produced by the back pressure. That is when you do control ventilation and keep all the valves closed, and when you squeeze the reservoir back, or your ventilator is giving a positive pressure, then what happens? The gases not only travel towards the patient's lungs through the common gas outlet, part of the gas will try to go back towards the vaporizer and the back bar towards the vaporizer. So this is called the back pressure effect. And this back pressure effect is defined as pumping effect and pressuring effect. Can anyone tell me what are the what is the effect of pumping effect on the vaporizer output or concentration delivered, and what is the effect on the vaporizer output by pressurizing effect? Any
Pumping
idea?
effect is when the oxygen flushes.
Oxygen flush is nothing to do
No,
with
so the
it.
reservoir bag is pressed and there is backflow into the vaporizing chamber. So more vapor gets saturated into the carrier gas and more concentration ends up getting delivered than what we actually set it for.
Very good. So concentration, output concentration of the vaporizer will increase to more than what you have set in the dial by the pumping effect caused by the back pressure. This is one simple sentence you should keep in your mind. The pumping effect caused by the back pressure effect will increase the vapor output from the vaporizer more than the dial setting that you have made. Why this happens is, as she said, there is back pressure which is preventing the outlet of the vaporizer sending the gas out. So there is accumulation of the fresh gas flow as well as the delivered gas outlet at the outlet, which picks up more vapor and comes and delivers. So the change is due to generation of the positive pressure. When the bag is squeezed, the pressure in the breathing system increases. This pressure is transmitted back both to the bypass channel as well as the vaporizing chamber. The fresh gas tries to move forward and gets compressed between the bypass channel and the vaporizing channel. And during sudden release of positive pressure, after you give an inspiratory squeeze, either you do it manually or the ventilator does, then during exhalation, the bag is released. So during that release time, when the positive pressure is taken, the previously compressed gases now suddenly expand in all directions, and some of the rapidly expanding gases containing vapor enter the inlet of the vaporizer and cross over to the bypass channel, and the final output concentration, normally a vaporizer bypass channel does not have any vapor because it just transmits the fresh gas through that. So this vapor due to pumping effect is additional. When this bypass vapor flows across to the exit, it meets the vapor from the vaporizing chamber. So the addition of bypass vapor to the vapor from the vaporizing chamber raises the final concentration, and the pumping effect increases the delivered concentration of the anesthetic agent. So that is the ultimate effect. The pumping effect increases the delivered concentration of the anesthetic agent. This is the answer that you have to give, and these are all the explanations. So these pictures will tell you how this is available in the howequipmentswork.com, and you are squeezing the bag. Some of the this is the flow towards the patient, and this is the back pressure that is going towards the outlet of the vaporizer, and you can see the vaporizing chamber being compressed from, and this is the fresh gas flow which is continuously flowing from the flow meter. So ultimately what happens, there is a part of the vaporizing material goes into the bypass chamber, which normally should not happen. Because of this pressure, it lets the vapor to go into the bypass channel also, and ultimately you find there is an increased delivery, higher concentration is being delivered. So these pictures will tell you serially, very easily, how the concentration gets enhanced by the back pressure effect. And what are the methods of reducing? This is another question they may ask you. By increased resistance, that is, you prevent the vapor getting into the bypass chamber by having a long inlet tube to the vaporizer, or you can do resist the increase by the here at the back pressure to reduce the amount of back pressure that is coming to the outlet, or you can do one-way valve here so that the back pressure does not happen. And lastly, you can this is the open one-way valve and closed one-way valve. So three methods for reducing the alteration in the output concentration of the vaporizer. One is to have the long inlet tube at the inlet to the vaporizer, number one. Number two, putting a by resistance, increase resistance to prevent the back pressure going towards the vaporizer. And three, by having a one-way valve which will open only for forward flow and prevent any backward pressure coming. Okay, so there is the one-way valve outlet. So these are the three methods which you have to remember to answer in the examination: long inlet tube, increase resistance at the outlet, and one-way valve at the outlet and the circuit. The pressurizing effect, on the contrary, is a very not much of an importance and doesn't cause that much back pressure effect or alteration. But in the pressurizing effect, what happens? It is significant only when you have a low gas flow, and it becomes effective only when there is a high gas flow, and it causes lowering the concentration because there is not enough time for the fresh gas to pick up the vapor. There is a low concentration. So pressurizing effect produces a lower concentration, whereas pumping effect produces an increase in concentration. And fixed flow adjustment mechanism, all this we have already dealt with. Safety features incorporated in modern anesthesia vaporizers are, these are all the safety features: color coding for specific agent, key fill bottles, low filling point port, secured vaporizers interlocking system, and there is a tipping that will not cause any overflow of the agent into the bypass chamber, and only one vaporizer can be used at a time by the interlocking mechanism. And the trace vapor is minimized and the vaporizers are in off position. In the earlier models of vaporizers, even when you keep it in off position, some amount of vaporization will come and join with the fresh gas flow. So that has been reduced to a minimum, and concentration dial output is all rotated counterclockwise. So this is a very important change. Earlier it was a clockwise rotation. Now it is made it counterclockwise so that you don't do it in a rapid fashion to increase the concentration. And the hazards are misfilling, contamination, underfilling, tipping, overfilling, and leaks. These are all the hazards also which are still present. And the interlocking system, this is the mechanism. Of course, this may be asked by showing you the machine and what are the methods of filling and their hazards. If it's a straightaway pouring method, opening the cap, then any agent can be poured and spilling will happen when you try to do that. And the vaporizer need to be in off position during this sort of filling. And whereas the desflurane you can fill even when the vaporizer is on, because the gas is not going through the vaporizer. So these all the other tech vaporizers, you have to keep the dial in off position and then only open this chamber to fill. Okay, the filling port. And this is the color-coded safety pin filling system for halothane and isoflurane. The red is halothane and the purple is isoflurane. And what is this? All of you have seen this? Huh? So this is the specific collar and the filling cap. So these rods are here. These holes have to go in and you have to fit in that. And this is the keyed filling system. There is a particular type of pin here. So the fill port you will have to insert like this and then do the filling here. There's a name for that, for this type of pin system. It is called Fraser-Sweatman pin safety system. Okay. And the components are, it's a keyed bottle collar, adapter tube, and vaporizer filler receptacle. So this is how you fix that. Put it inside and then tightly close it and then insert that pin into the slot here and then invert the bottle. Then it will automatically start filling. This is the way of filling the pin safety system or Fraser-Sweatman pin safety system. And this is a close-up view of how it goes into the slot and then gets the filling done. And these mechanisms are the same thing at the closer picture. So how we do all these steps. This is the easy fill method for sevoflurane. Okay, so there is a cap which is a self-sealing cap. It's a pin inside. You have to press this inside, and this pin will open the bottle, and you can see the liquid filling in the sighting glass or the level reader. And Dalton pressure of partial pressure is also part of that. That will, the meaning of what is the meaning of plenum vaporizer? This is a common word that is being used in the modern vaporizer. What is the exact meaning of the word plenum?
High resistance vapor.
Plenum means full, opposite of vacuum. Okay, it's a Latin word which means full. Something is completely filled up. So it was used in air conditioning terminology, applied to air that is forced in and cleaned and temperature adjusted. That is what is happening in our air conditioners. And plenum vaporizers are designed for use with continuous flow of pressurized gas and have high internal resistance. Okay? And they are modern version of the inverter and flow stabilized, perform equally well over large range of fresh gas flows. Now identify the vaporizer from the pictures and the clues. This picture is again a museum picture. It's one of sometimes just for the purpose of Osce, I have included this. Sometimes from a historical point of view, they may ask you. The world's first precision vaporizer, more idiot proof with the side filling port, precluding overdose from more filling. So this is called the copper kettle vaporizer. Okay? One of the oldest precision filling vaporizer. The features are, it is a measured flow, just like your desk floor end, no fresh gas will enter here. The copper kettle is heated by this here and then the pressurized vapor is added to the fresh gas flow. So fresh gas flow does not vaporize the volatile anesthetic agent. That is the thing in measured flow. Method of vaporization, bubble through temperature compensation, manual changes, no non-calibrated multi-agent out of circuit. These are all the features of that. So comparing this between these, you can see this is the regulator bypass chamber going there, and this is the flow meter going part of it. I'm sorry, part of it goes through the vaporizer also, and then the liquid level indicator is there, and gas outlet comes. And difference between Tech 2 and Tech 3, sometimes they may ask you. And see, you can, this is the Tech 2 which you saw earlier, front dial, mainly constructed for halothane, and it's a temperature compensated by bimetallic strip and non-tippable, no interlocks, no feed filler, volume maximum is 750 ml. Whereas Tech 3 variable bypass, flow over with wick, automatic thermocompensation, it is agent specific, and it has a long inlet vaporizing chamber to prevent the back pressure effect, as I told you, and control size of control channel, filling and draining at the bottom. You can see this is the cap which you remove, fill the thing, and it will have a groove on the top. This cap will have a groove, and there will be a nozzle projecting inside. And you, by inverting this cap and then unscrewing that nozzle, the agent can be drained out through this. So whenever you want to empty the vaporizer, you can do that by inverting this cap and then unscrewing that nozzle that is coming there and then trying to remove the liquid through this. And the more the modern vaporizers are, the more accurate they are. So the Tech 4 vaporizers, this is the remodeled Tech 3. So every time they improve the version, they called it the newer model, Tech 4, Tech 5, like that. So all the defects that were there in the older machines were removed, and the main problem is the off position. Some of the incoming gas flows from inlet to one of the channels may carry some vaporizing vapors. That was the problem with the older machine. And in the on position, it splits into two variable bypass mechanism is working. So goes to the vaporizing chamber as well as the bypass chamber. And the disadvantages of this Tech 4 are, it is difficult to operate with one hand because you have to press the lever and then rotate it. So that cannot be done with a single hand, and it requires an yearly service. And this is the Tech 5 model, Zero Tech 5. So the features are, again, it's a variable bypass, flow over wick, out of system, temperature compensated, concentration calibrated, and agent specific. The advantages of Tech 5 are that it is a helical IPPV assembly which is minimize the effect of positive pressure. So pumping effect is very much reduced in Tech 5. Volatile agent capacity increased from 125 ml to 300 ml, and it can be operated with one hand. Just press this white button and rotate. So you can use it with the one hand, contrary to the earlier models where you have to press the lock separately and then rotate the handle and the dial setting. And internal baffle system designed to prevent liquid from reaching the outlet. And all of you must be very familiar with this. Can you identify these things? What is shown here? Have you all gone to sleep?
Desflurane vaporizers. Sir.
Different brands of desflurane vaporizer, nothing but that. Okay. So this is Tech 6 G Healthcare. This is the Draeger desflurane vaporizer. This is a Penlon. Okay. The color coding is very important. And if you can see, this is the lock restrainer, and sometimes this alone is asked in the Osce. What are all the various features of that? We will discuss that later. These are all the different brands of desflurane vaporizer. And what are the methods of temperature compensation? This is another method which you have to know. So there is a metal rod which can move up or down depending upon the temperature. So higher the temperature, once the temperature increases, what happens to the vapor production? Will it increase or decrease?
It will increase, sir.
Increase. So you have to adjust the bypass flow, fresh gas flow coming into the vaporizing chamber to maintain the same concentration. And when the temperature drops, the vaporization will decrease. So you allow more vapor to come in to pick up more vapor. Okay? More fresh gas to come in to pick up the vaporizer. And there are liquid bellows type, which again shrink and when expand. This is the two methods. Then the modern methods have what is called the bimetallic strip. Okay, so there are two different metals which are attached together. In high temperature, it will the metal with a faster temperature absorbing capacity will bend towards one side, and at lower temperature it will shrink. So by that it will adjust the flow. So you can see here, this is the bimetallic strip. This is the inlet from the fresh gas flow chamber. So at high temperature, it has expanded and it is uploading. At low temperature, it is shrunk and it is opening the path. Now, what are this shown here? This is called the EC film for isoflurane and color-coded caps for different agents. Okay, and what is shown here? Can you name the arrow marks that are shown here?
Filling port is the Aladdin cassette.
Or desflurane. You can see color coded and des name is also written. What is this?
The filling port, sir.
Filling port. Very good. So this arrow part, this is called filling machine mechanism. Not SAFETY, it is SAF-T fill mechanism for desflurane, and these are all the inflow and outflow spring-loaded valves. Okay, so when you fix the cassette into that, that will deliver the gas inside and outside, so the inlet and outside to the cassette. This is the EC fill for sevoflurane, which you saw in the earlier picture. And what is shown here again, what we have seen already, the Aladdin cassette, color-coded Aladdin cassette for ISO, CO and desflurane. What are the parts of the Aladdin vaporizer? It's got an electronic component and a pneumatic component, which we already seen. What is being done here? This action. So with this, Aladdin cassette is either inserted or being removed. Okay, any one action can be there. There's already another cassette lying here. There's this one, either they are trying to fix it or trying to remove it. So that is the way it is done. And these are the comparisons between the various types of models of vaporizers. And this is DIVA, direct injection of volatile anesthetic agent. This is the most modern. How does it work? The DIVA is a measured flow vaporizer. Just like your desflurane, it's a measured flow, can be used for all the modern anesthetics, including desflurane. It has two sections, one a plug-in vaporizing module for a particular agent and the module that is part of the anesthesia machine. So this is the picture of that. Sorry, this is the module which has one. So there is a liquid containing reservoir from which by gravity it goes into a dosing chamber, and from there it's added to the fresh gas chamber, and then fresh gas flow coming here. Then there is a heating mechanism where vaporizing occurs and the flow comes, and flow agent goes in. So hazards associated, of course, we have seen that overfilling and all that earlier. Now, this is the last slide which you have to know. What is shown here? Can you identify this? Can anyone identify? Are you able to hear me?
Yes, sir.
Yes, sir.
Just name this equipment. This is called the anaconda vaporizer.
Anaconda.
Anaconda. Okay. So this is going to be, where is it used? Any idea?
In ICU setup, sir.
Good. What is commonly used? It is miniature anesthetic vaporizer and a HME, heat moisture, humidified moisture exchanger, heat moisture exchanger filter combined together. So this is nothing but a combination of a miniature vaporizer with a HME filter. Both are combined together, mainly used for sedation in intensive care unit and outside operating rooms. And it is destined to deliver only isoflurane and sevoflurane. Okay, only two agents can be used with that, and available presently in two different internal volumes of 150 ml to be used in patients with high and low tidal volumes. So instead of using propofol, midazolam, or other agents to keep a patient on ventilator quiet, they thought elimination and recovery will be faster if you use a low concentration of volatile anesthetic agents along with the air or oxygen that is being pumped from a ventilator. So it is mainly used for patients on in ICU to tolerate the ventilation. So it is attached to the endotracheal tube. It has got a, this is the filter, this is the white piece coming from the ventilator. So there is a constant supply of the anesthetic agent through an injection syringe pump, and then it gets vaporized by the fresh gas flow that is coming from the patient, and then it is reabsorbed and then reused. There is a carbon layer inside which will trap the exhaled vapor also and reuse it, so that very small concentrations are only required and it does not cause any hemodynamic instability or anything. So this is becoming more popular in that. Now, lastly, is author Ernest Goodall. What are his contributions to anesthesia? It's all given
And
The
here.
oropharyngeal airway, sir.
First thing you must say is stages of anesthesia. By open drop ether method, he described 4 stages. So stages of ether anesthesia was first described by this man, because of inhalation anesthesia became popular because of his contribution. And of course, oropharyngeal airway is another one which he designed. And the original one was a metal one, not the plastic that we use here. So he used different sizes of this black metal for oropharyngeal airway. And the mechanism, so we will not go into that. The name that we have to remember is this. And of course, how the theory of volatile anesthetic agent, how do they work and all that can be part of that, but it isn't now time to discuss that. So we'll stop here. And any doubts, any questions? For those who want to clarify something.